When I heard I was going to be part of the headache group, I thought, my patients with headache usually don't like to come for vestibular testing just because it's so symptom producing. But it's so important because headaches overlap. Many of our patients with headaches also have symptoms of dizziness. They have imbalance concerns. So it's important that we consider what options we have for headache care. And that includes oftentimes ruling in or ruling out other causes, which could be vestibular contributors. So as we know with patients with headaches, patients with dizziness or imbalance, one of the most important things that we have to do is get detailed information from these individuals. And I will say for our patients, just in general with dizziness and imbalance, we're going to be facing more and more older adults with these concerns. It's estimated that 1 in 5 older adults by the year 2030 will be over 65. So complaints of dizziness and imbalance are going to be more concerning. And these individuals will have more comorbid conditions that could be contributing to their symptoms and leading to other symptoms, including even developments of neurologic symptoms and needing more physical therapy and occupational therapy care. For these patients, as they reach older age, they are highly susceptible of having vestibular symptoms. And it's estimated that by age 65, many older patients have dizziness concerns, upwards of about 27%. And that raises to almost 40% by the age 80. So really a need for us to get together and to work as interdisciplinary teams to try to figure out what could be the culprit for these symptoms. But case history is often the first thing that we need to do. When considering, is there a concern for something peripheral vestibular for the patients? Is there something that could be more inner ear related? That's when there might be a thought of we need to include vestibular testing into our workup. And I will just have this slide. So I'm a vestibular audiologist. I do vestibular testing. That's my passion. That's what I teach. That's what I practice. But I will say the caveat with this is that vestibular testing is not going to yield a diagnosis. We have to be looking at all of the facets of patient care together, including that most important part, which is the detailed case history. Our vestibular tests are mostly going to help us with identifying physiology. And if we have to narrow in on differentials, this is where we're going to want to include it because it is going to help us narrow down possibly if there is or is not a peripheral vestibular cause. So just an example here, if we have somebody who maybe is seen in the clinic, maybe vestibular testing is performed, and we see right beating nystagmus, that's not necessarily going to tell us where the problem is, but it is maybe going to point to that there's some sort of vestibular asymmetry that we need to consider, but we're going to need other things in the mix. What vestibular testing can do, and really the value of the testing, is that it can help us objectively identify function of vestibular system. So what's great with vestibular testing is that it can help us look now with advancements in testing. We can look at all 5 vestibular organs on each side. We can get an appreciation for both superior and inferior vestibular nerve function. We can help identify site of lesion, right ear versus left ear, where the components can be for as far as pathology. It can help us determine need for additional testing. So maybe we see something with our testing that is pointing us to, maybe there's something central going on that can lead us to other testing. It can help us guide treatment planning, and we work so closely in audiology with our partners in physical therapy and occupational therapy, and often our testing helps to identify next steps in their care and can help with the treatment planning for that. It can also help us with identifying kind of the status of compensation. So if somebody is dealing with some sort of vestibular deficit or balance disorder, it can help us identify where they are in the compensation stage, how they're recovering, and where we need to go. So these are really the times where we need to consider adding vestibular testing into the mix. We have many different vestibular tools in our toolbox, and I'll talk about just some highlights of the most commonly ordered and the most commonly performed in the clinic. So we have lots of tests that we can do. And the most common tests that we have are looking at, again, focusing in. If we think about sensitivity and specificity of our testing, the most common use for our testing would be to identify peripheral vestibular dysfunction. And with that, the most, or kind of the readily available way that we can do this is indirectly looking at vestibular ocular reflex function. So we have many tests, and I'll kind of dive into a little overview of these tests in just a moment. But these tests help us look at kind of like a vestibulogram, like a hearing test. We can look at vestibular function across a frequency span to get an idea of where there might be a deficit and how this might correlate with patient symptoms. We can look at all 5 vestibular organs, as I mentioned, on each side. We can look at semicircular canal function of all semicircular canals. We can also look at otolith function, looking at both utricle and saccular function and their respective kind of signals as they're traveling along the superior and inferior vestibular nerves. In addition to that, and a lot with our partners in physical therapy and occupational therapy, we can look at functional performance. So not only can we look at site of lesion and more end organ performance, but we can look at functional performance, so how patients are able to utilize their vestibular system and how this is able to be integrated with other sensory systems, such as vision, proprioception, which helps us with our balance. And I will give a plug to also hearing. So one thing that we try to do as far as putting together our test battery, if patients are seen, they're not going to receive a cookie cutter, everybody's getting the same test. It's really going to be streamlined based on the patient's symptoms, because again, that's the most important part of the evaluation. So we tailor our testing to really help providers understand function, understand if there is a peripheral vestibular cause, or if perhaps there's something central that we need to rule in or rule out. We use a clinical question approach, so every patient that we're seeing, we try to identify based on review of their past medical history, based on what they're presenting with their symptoms, what could be a potential differentials for us, and then we're tailoring our testing to help rule in or rule out those clinical hypotheses. We know that administering all tests and getting back to our patients with headaches, so kind of this first module of speakers, they're not going to do well with all of these tests. So we have to be very mindful and make modifications so that we can get the information we need from our patients. Oftentimes, our patients who undergo vestibular testing, because we're eliciting vestibular responses, for those with migraines, for those with motion sickness, they can have very strong responses. So we have to think about what are some alternatives that still answer the question, but yet yield the information we need to help best manage the patient and make those determinations for next steps in care. So once we have our clinical hypothesis, we then can start tailoring our testing. And the things that we do, so again, we can evaluate our testing in a number of ways. The most common way that we do this is by evaluating the vestibular ocular reflex, which is the compensatory eye movements that are produced every time we activate the vestibular system. So it should have, with normal activities of daily living, which is more kind of mid to high frequency range for vestibular function, it should have this 1-to-1 ratio between head movements or body movements, producing compensatory equal and opposite eye movements. We indirectly measure these eye movements through the use of video oculography goggles or video nystagmography goggles. Or even we can now use camera systems that we have set up in our lab that we don't have to put goggles on patients at all, but we can track pupillar displacement when we move the head. And that can help us quantify this 1-to-1 ratio between head movements, activating vestibular system, and equal and opposite eye movements. The easiest one that we can tap into for the vestibular ocular reflex response is looking at horizontal canals. It's just the cleanest data, but we are able to evaluate VOR responses from any semicircular canals, and there's even VOR responses from the utricle, so linear responses that we can measure as well. So ways we do this, we can look at this across a frequency spectrum. So we can do testing in the clinic. Probably the most commonly used that's been in existence since the 1960s is caloric irrigations. So this is where applying a temperature gradient, so some sort of medium such as water or air, into the ear, and we're applying temperatures that are above and below the body temperature so that we can cause endolymph fluid within the ear to move, which indirectly elicits either an excitatory or inhibitory response of the system. So we're indirectly evoking a vestibular ocular reflex response. We can then quantify the responsiveness of the right ear system versus the left ear, and we can calculate, based on a formula, an asymmetry response. This helps us identify if there's some sort of pathology in the system, a weakness based on this asymmetry. It doesn't imply that somebody who has a 50% weakness has 50% loss. It's just based on this alone, this asymmetry score. That's where we're seeing a reduced function. We can look broader across the frequency range with rotational chair testing. So this is having somebody secured into a chair that actively rotates. What's exciting is that we have rotational chairs coming out. They are traditionally just looking at horizontal canal, but there's actually chairs on the market now that can look at all semicircular canals. So we can put somebody in planes to activate posterior canal, anterior canal function, which is wackadoodle to me, anybody who wants to go through that, but you can, which is great. With this, we can look across this frequency range, and we can look at that one-to-one head movements or chair movements in this case, registering eye movements. And based on the system of the chair, we can apply norms to know essentially what we would expect somebody's VOR gain, that one-to-one ratio, to be as we apply these different rotations or frequencies of chair movements. We can do some things which is most common to a head impulse test. So if you do this at bedside as part of the HINTS exam, you can do video head impulse testing. You can use goggles. So this is an example where we had goggles that we had on a patient that elicits this reflexive eye movement that we're recording, comparing it to the passive head movement of the examiner moving the head, and then we're quantifying the gain of the response. You can do this now with just a camera system, which we have set up, which is great for pediatric patients who may not like to wear the goggles. So site of lesion we can examine with our testing. So as we look at just VOR across the frequency range, right now most traditionally for caloric irrigations, rotational chair testing, it's just horizontal canal. We apply video head impulse testing to look at anterior canal, which is going to give us an appreciation for the superior vestibular nerve function. We can also utilize video head impulse testing to look at posterior canal, so this is going to let us know about inferior vestibular nerve. For the most basic test that we may apply for our patients, which is video nystagmography. Older systems use electrodes, which was called electronystagmography, but most systems now use video goggles. We use a battery of tests within this, and it's considered a parallel loose protocol, meaning if any one of these sub-tests that I have listed here are abnormal, that would tell us that there could be something going on, possibly within the peripheral vestibular system or central. For this, as part of any our test battery, we'll do bedside examinations. We'll do ocular motor testing, looking at saccade performance, which is typically random saccades or anti-saccades. We'll do gaze evoked testing, so both spontaneous nystagmus searching and then gaze evoked with and without fixation. We'll do pursuit tracking, and we can even do optokinetic testing. We'll then do facets to look at vestibular asymmetry, such as head shake nystagmus testing or skull-induced nystagmus testing, where we'll use vibration applied to the mastoid. And then we'll do positional testing as well to look for any signs of vestibular asymmetry or any signs of benign paroxysmal positional vertigo. And then finally, calorics. So as I mentioned, calorics are these indirect tests to look at applying a temperature medium we apply air or water to the ear. You can even do ice. And we're eliciting responses with warm air or water or cool air or water, and we're applying this formula to look at an asymmetry. So this is just an example here plotting just a normal response we're measuring nystagmus. Nystagmus has two phases. It has a slow drift of the eye, which is the vestibular ocular reflex response we're measuring, and then a saccade movement, which is the fast reset that you can see at the naked eye. For our recording for calorics, we're just looking at the slow drift, and we're measuring the peak response for right ear compared to left ear, and then applying that symmetry ratio. We can get an appreciation. So here we have for the right ear, we have weaker responses compared to the left. So based on that asymmetry ratio, that would imply that there could be some sort of right vestibular hypofunction. You can have results where you have low results for both the right ear and the left ear, and that could tell us that we have a bilateral vestibular dysfunction. And then there's even times where we can have somebody who has some sort of bias in their system. So they have vestibular nystagmus kind of pre-testing. So for example, let's go back to my example earlier where I said somebody had right beating nystagmus. If they have this spontaneous right beating nystagmus, if we apply caloric irrigations, it's still going to be there, and it might enhance every time that we're eliciting a right beating response, or it might decrease a response every time we're eliciting a left beating response, and we can get a bias in the system. And this can help us know a little bit about dynamic compensation for patients and where they are in the recovery process. Moving on, rotational chair. So this is an example of somebody set up in the lab with rotational chair. So their head is secured to the chair, they're seatbelted in. We can do this in enclosure. There's open settings now, and even that wackadoodle one I talked about where you can get all planes of the semicircular canals. The idea with this is that we're further investigating function of the system. So we're looking across a frequency range from low to high frequency. It's only in a mid-frequency range, but it is a higher range than caloric irrigations. But most of our chair systems are just limited to low frequency, just the horizontal canal at this time. There's two main tests that we can do with rotational chair testing. We can do something called step velocity testing. You take somebody in a chair at 0 point, so not moving. You ramp them up to a constant velocity, and then we record nystagmus response over time. The vestibular system applies to acceleration and deceleration. So when you have it at a constant velocity, there's no more pull on the system, on the peripheral system, acting upon that system, so nystagmus is going to decline over time. And we can measure how long it takes nystagmus to decline when we're eliciting responses in a rightward direction versus left. We can also do sinusoidal harmonic accelerations. So this is looking at chair movements. Imagine like a washing machine. Somebody's in a washing machine, we're moving the chair back and forth, and we're applying this at different frequencies. So we're looking at this VOR response, 1-to-1 ratio of chair movements to eye movements across low to more mid to high frequencies, and we're establishing if there's any difference in how the eyes are moving compared to the chair movements. Video head impulse testing is a higher frequency test. So this is looking at more natural or active head movements throughout day to day. We can do this with the goggles, which is the example of the individuals here. And we have high-speed cameras that are capturing these eye movements. We're measuring the VOR response. So every time there's an eye movement, which is the yellow line compared to the orange line, which is head movement, we should be quantifying this equal and opposite response. For those with vestibular dysfunction, what we're going to see is reduced gain, and we'll often see these corrective saccade movements so that we can realign gaze stability for patients. So you'll see overt saccades, which are the ones you might see at bedside for Hintz exam, or you can see covert saccades in this case, and these occur during the head movements. As patients go through vestibular compensation, we can start to see, and this is where vestibular physical therapy comes in, we can start to see change in movement of overt saccades to covert saccades over time. So we're using central mechanisms to help us with compensation. So the role of the corrective saccades, while we look at gain of the VOR, that 1-to-1 ratio, that really lets us know how the vestibular system is functioning. But the corrective saccade can tell us a little bit about recovery of function. So as we start to go through compensation, we start to have overt moving to covert. And that's really what's represented here. So we can see somebody who had, I think they had a vestibular nerve section. They had strong overt saccades at day 2, but then by the time they got to day 5, after their surgery, where they're already starting to have covert saccades introduced, which is the bottom box there, which shows you that compensation can even start to occur very quickly. And as we start to employ vestibular rehab, it can speed up the process. We may always have a deficit, so that VOR gain may always be impaired, but how patients functionally are performing is improved because of the introduction of these covert saccades and central mechanisms helping them. Okay, moving on. So we can also look at otolith system. We can do this a number of ways. We can do it with rotational chair testing, which is kind of putting the utricles off axis with rotations. More commonly used, though, is called vestibular evoked myogenic potential testing, where we can look at both saccule and utricle responses. For these VEMP responses, our otolith organs, they respond to linear acceleration and deceleration. They also can be responded to loud sounds. So we can use a very high intensity sound to elicit indirectly this reflexive response from the otolith organs as they travel and send signals down the neck for cervical VEMPs or to the extraocular muscles, and we use the inferior oblique muscle to record this for our ocular VEMPs. With this setup, and this is somebody, a past assistant from my lab, we can have set up here where we can look at an inhibitory response for cervical VEMP. So this is looking at inferior nerve for C-VEMP pathway and saccule. And we can measure over time as this response from sound from the ear, traveling to pick up with electrodes on the neck. And we can look for this a response that's a peak response, positive to negative response, that has expected latencies based on travel time to pick up the recording. We can also do the same with ocular VEMPs, which is an excitatory response where we have negative peak to positive peak. And again, we can measure latency of time and also expected amplitude for these responses for healthy individuals. One of the most commonly used reasons why we use VEMP testing is to evaluate for third mobile window deficits, such as superior semicircular canal dehiscence. With this disorder, individuals can have a thinning of the temporal bones over the semicircular canals or the labyrinth itself, or even missing bone. And that can apply just like a house. If you had your window open, sound has a way of getting into the house. The same happens with the vestibular system. The sound intensity and sound pressure can activate parts of the vestibular system and auditory system and make patients more susceptible to symptoms. We can see with our VEMP testing, we can see higher amplitude responses, and even if we did threshold searches, so lessening the sound, we can see still positive sound or positive responses because we have this additional opening into the labyrinth. Finally, we can get into, so we have objective testing. We also have functional performance testing that we can use to evaluate the vestibular system. Some of these functional performance testing are going to look at how patients are doing over time. So we can use tests such as dynamic visual acuity, where in essence, for some of these tests, we are activating the vestibulo-ocular reflex, but instead of measuring gain of the response, we're actually trying to elicit how patients can utilize their vestibular system to see things clearly. So we ask patients, you can do this with an eye chart, you can do this with a computer system. We ask them to actively move their head or passively move their head and tell us on a chart how low they can see visual acuity. So we'll do this first with head still versus head in motion, and then we can quantify a difference to let us know how they're able to utilize their vestibular system for gaze stability. For patients who go through compensation, they have improved gaze stability over time, so this is a good outcome measure for us. We can also do posturography performance testing, and there's a number of gait performance testing you can do as well to look at how someone's able to engage their vestibular system or even just their whole balance system to help them with gait and transfers or postural stability. So this is an example of a Burtec kind of virtual reality postural control system. There's even older systems that are still in existence where they have a visual screen, and at times the floor somebody's standing on or the visual screen can move, and the person is going to have to adapt to these sensory disturbances to keep themselves upright. You can even apply a head shake, which is what the model's doing here in this picture, wearing a little metronome on the head. You can apply a head shake, and by having your eyes closed, standing on a firm support surface or moving kind of sway reference, so every time the person moves, the platform's going to move to support surface with head in motion, you can actually help to identify vestibular asymmetry by doing this. So this can be done at bedside, doing just a standing Romberg, eyes closed, having a patient move their head back and forth slowly. You can start to see fall reactions with this that can tell us that maybe there's some sort of vestibular asymmetry. So lots of tricks, lots of tools in our toolbox, lots of things that we can do to help identify problems within the vestibular system. I think for the sake of time, I'm just going to kind of put this last slide up just with different questions that we may ask as clinical audiologists, trying to differentiate what could be the cause for patient symptoms, and helping us and helping all of you to rule in or rule out peripheral disorders, vestibular disorders, or maybe help you guide your management planning. So this is just an example of some of the questions that we would start to think about clinically and how we might put together our test battery to help us identify what could be going on for the patient. So again, we have many different tools in our toolbox, many things that we can use to help identify pathology. That's just a little bit of the tip of the iceberg. And I'm happy to answer any questions you may have. Thank you.